Thank you, Celeste. Good afternoon, everyone who has been with us since the start of today's conference, and a very warm welcome to those who have just joined us. I'm Sui Gyang, lead psychologist and head of Care and Wellness Office with the Emergency Behavioral Sciences and Care Unit of the Singapore Civil Defence Force. I will be the facilitator for this session, which is on crisis and mental health. To our friends and colleagues in Singapore, the day started with a heavy morning rain. I hope you are as relieved as I am to have a bit of respite from the sweltering heat that we were having in the past few days. To our colleagues in the region, I hope you have had a good tea break before joining us. And to delegates who are streaming in to the conference today, we are so happy to have you and hope you are as thrilled as us for upcoming presentations lined up for you. Here's a quick and gentle reminder to all our colleagues and delegates with us on this session not to record or reproduce any content from the presentations that will be screened on public platforms, for instance, social media. However, for non-sensitive content, you are free and encouraged to share your experiences and thoughts on our social media. And please don't forget to hashtag ACOP 2022. Delegates can also find the recordings of the conference presentations on this platform after the day's proceedings have ended. For this special session on crisis and mental health, we have a total of 3 presentations, with each presentation lasting a total of 15 minutes. Our speakers are live with us and they will be taking questions from the audience in the combined 10-minute Q&A portion at the end of this special session. Again, we strongly encourage all attendees to post any questions or comments that you may have for the presentations via the Q&A tab. Without further ado, it is my honor to introduce the first presenter for this session. Ms. Jessie Jani Thanarianto is a master's student at the University of Pennsylvania studying behavioral and decision sciences. Prior to her graduate studies, she worked as a behavioral sciences research analyst at Home Team Behavioral Sciences Centre, Singapore. Her current research interests include psychological resilience, cyber psychology, and crime. Her published works include Maintaining Cyber Wellbeing During a Pandemic and How to Prepare for the Next Pandemic, Behavioral Sciences Insights for Practitioners and Policymakers, and Social Media Response After an Attack, Perspectives from the Jakarta Bombings. In Learning from Violent Extremist Attacks, Behavioral Sciences Insights for Practitioners and Policymakers. She holds a bachelor's degree in psychology from Universitas Putra Surabaya, Indonesia, where she received the School of Psychology's graduate with the Best Academic Performance Award. In her presentation, Ms. Jessie will be sharing with us her research, which aims to understand religious coping strategies that have been used by communities in Indonesia to deal with crises such as natural disasters, violent extremist attacks, and the COVID-19 pandemic. Through this sharing, you will learn the role that religion plays in helping community members make sense of their life experiences, achieve a sense of control and comfort, and draw social support. We will now start the presentation by Ms. Jessie. Ms. Jessie, please.
Good morning, good afternoon, and good evening to everyone here today. My name is Jessie, a graduate student at the University of Pennsylvania, United States. And today I'll be sharing some of my research on religious coping during community-level crises in Indonesia. And this will be the outline of my presentation today. As we know, our world is no stranger to crisis. We have seen armed conflicts and violent extremist attacks, natural disasters, and extreme weather events, as well as public health emergencies such as the COVID-19 pandemic. Talking about crisis, research has found that how we manage and respond to a crisis, or in other words, how to cope with it, not only determines individual psychological outcomes, but also community resilience, which is a core component of crisis recovery. Studies have shown that each community has their own coping strategies. For example, studies among refugees at the Myanmar-Thailand border and survivors of the 2004 Asian tsunami preferred self-reflection, spirituality, and other unique individual and social coping strategies more than formal mental health services. So, due to the diversity of coping strategies, in order for us to help communities more effectively, there is a need to understand the coping strategies that a specific community tends to use. Indonesia is a country located in Southeast Asia with a population of more than 270 million people. It is a multi-ethnic, multi-religious society, and it also has the largest Muslim population of all countries in the world. Religion plays an important role in the country, but it is common for people to identify themselves along religious lines. Most Indonesians view religion, God, and prayer as an important part of their lives. Indonesia has also faced various community-level crises, from natural disasters, violent extremist incidents, and the country was also a major COVID-19 epicenter last year. So keeping in mind the current literature on the diversity of coping strategies in different populations, we sought to understand how Indonesians deal with crises. To help answer this question, we took the COVID-19 pandemic as a case study. The COVID-19 pandemic was a prolonged major crisis which significantly impacted people's lives, including areas of health, work, finance, interpersonal relationships, and religious life. As such, in this study, we aim to understand the different ways people use religion to cope with the COVID-19 pandemic in Indonesia, as well as the impacts of using religion to cope. We conducted in-depth interviews with 10 interviewees, which was also supported by a literature review of empirical studies focusing on religious coping in crises in Indonesia. Here is some information on the profile of the interviewees. 50% of them were males. As for religious affiliation, 40% were Muslims, 40% were Christians, and another 20% were Catholics. In terms of age, their ages ranged from 21 to 46 years old. All of them became a part of their current religion since they were born. And in terms of religious involvement, 50% were a member of a religious community, 30% held certain roles or often helped out in their community, while 20% were religious leaders. And all of them were living in Indonesia throughout the COVID-19 pandemic and were impacted by the pandemic in at least one area of life, either it was financial or work, interpersonal relations, or health. Using a semi-structured format, interviewees were asked about their participation and adherence to beliefs and practices of the organized religion, their experience in dealing with the COVID-19 pandemic, as well as how they made sense of the pandemic from a religious perspective. So here I present the findings of the study. First, I will talk about the use of religion coping in general, and then I will discuss 4 aspects of religion that facilitated coping among interviewees. The study participants, first of all, revealed that seeking support from family and loved ones was their most used coping strategy during the pandemic. However, religion was still commonly used. For example, an excerpt from an interview with a 25-year-old female suggested that religion might be her second most commonly used type of coping. Meanwhile, another interviewee revealed that he doesn't usually tell other people about his problems. However, he has an internal conversation with a higher being, which in this case he calls God. Results of the interviews suggest that there are 4 aspects of religion that facilitated coping: the beliefs and teaching of the religion, activities or rituals, a community of people sharing the same belief system, and religious leaders who are authority figures and sources of support. So first, The current study found that religious beliefs influence the appraisal of events. When a crisis happens, people have the tendency to question why it happened, or in other words, they try to make sense of the crisis. A prominent theme identified from the interview was that the interviewees believed that a higher being has a plan behind the crisis. For example, this 32-year-old male interviewee believes that everything has been determined with an underlying reason or wisdom behind things. Interviewees also believe that crises are a test, aiming to increase their faith, devotion, and reliance on a higher being. With regard to the pandemic, some interviewers also mentioned that it was sort of a reminder of their limitations, such as that there are things that they cannot predict, or that they just needed rest, since they usually had worked long hours before the pandemic. The results of the study also suggest that religious beliefs were a source of consolation and hope during the crisis. So, for example, there's a belief that God does not give problems that is beyond people's abilities, and this was thought to be comforting. Another interviewee mentioned that even though he believed God is just and can punish, God's forgiveness is much bigger. And the view that religious beliefs are a source of hope is captured in this excerpt, in which the interviewee suggests that without faith, there is no hope. And when she knows that there is a higher being to help her, she feels strong. So, moving on to religious activities. There are 4 types of religious activities that are used to cope with the pandemic. First, prayers, which can be addressed to a higher being, and it can contain whatever the person wishes to communicate. But it can also be topic specific for a special purpose. For example, prayers about outbreak or prayers to specially request for something. Second, reading religious teachings. This can not only take the form of reading religious books, but also watching sermons and reading religious content online. And then spiritual quiet time. For example, zikr, which has a literal meaning of remembering God, is a form of Islamic meditation. Christians also engage in quiet times called devotions, and praying and reading religious books are often included in the quiet time. Fourth, sharing sessions. Some religious communities organize small groups, either formally or informally, where members meet to share their experiences, life challenges, and these sessions are seen as a two-way activity. People have an outlet to share their difficulties, but also learn from other people's stories. And this can be seen as one of the benefits of being involved in a religious community. The interviews revealed that religious communities have the role of facilitating the provision of social support. They can provide instrumental support, that is tangible help like money or masks and oxygen cylinders during the pandemic. An individual within the religious community also give encouragement to each other by sharing religious concepts or teachings that they believe to be relevant for a specific situation. The religious community also facilitated the sharing of information related to the pandemic through informal and formal networks. And this could be on public health measures and well as also changes to religious practices. Lastly, the religious community also facilitated companionship, that is the act of accompanying or being there during hospitalization, social isolation, or stay-at-home period during the pandemic. All these kinds of support can be sought and given within one community or place of worship, but also even between communities, that's for example, one church and another church. In the current study, religious leaders were also identified as a source of authority and sources of support. So there was a source of authority when it comes to like making sense of the pandemic or adapting religious rituals. So they had discussions to resolve differences in opinion in relation to the changes to religious rituals during the pandemic. And so for some people, religious communities are their main support system, and religious leaders often become the first person to know or the first person people turn to when they face difficulties during the pandemic. So to recap the findings of the study, one learning point is that the nature of the crisis may influence the use of religion to cope with the pandemic. And actually, prior research has found that religious involvement is more likely when the crisis is perceived as not being able to be repaired. So, for example, the COVID-19 pandemic could be one of those cases. Religion also provides a framework for understanding and interpreting the crisis. And studies have found that when people redefine the crisis as benevolent, it can lead to more positive feelings and adaptive psychological outcomes in the long term. However, when people redefine the crisis as a punishment, it can lead to negative psychological effects. The findings that religious communities promote seeking and giving social support is also supported by extensive quantitative studies on religious coping in different religious populations. And lastly, another key takeaway is that the significant role that religious leaders play in encouraging behavior change during crisis. So in light of these key takeaways, it is important for policymakers, mental health professionals, and religious leaders to work together to promote positive psychological outcomes and effective crisis management. So policymakers, for example, can work with religious leaders to encourage people to carry out measures to manage the crisis. And for example, when adjustments to religious activities are needed, policymakers should work with religious leaders in communicating such changes. Mental health professionals should also be mindful of the various religious beliefs when working with populations that are religious, and work with religious leaders to co-develop long-term interventions to strengthen resilience. And additionally, religious leaders and other key figures in the religious community should also be trained in PFA. With regards to limitations and future research, future studies should explore the use of other religions or belief systems. For example, the use of indigenous belief systems that might be common in some parts of the world. And future studies should also study the use of religious coping at different stages of the crisis. So that's all for my presentation today. I thank everyone for listening, and I welcome any questions that you may have. Thank you.
We thank Ms. Jessie for the insightful presentation. The presentation has certainly shed light on the important role that religion plays in helping individuals cope with crisis. Not only does it help them make sense of their predicament, it also offers hope and facilitates community support, which may also bring about community recovery after a crisis has happened. Thank you, Ms. Jessie, once again. The next presentation we have is by Dr. Jared Ng. Dr. Jared Ng is a senior consultant psychiatrist at the Institute of Mental Health Singapore. He heads the emergency and crisis services in the hospital and is also the program director of a psychiatric crisis response service in Singapore. He is a senior clinical lecturer with the Yong Loo Lin School of Medicine, National University of Singapore, and an adjunct assistant professor with Duke NUS School of Medicine, as well as the NTU LKC School of Medicine. Dr. Ng obtained his Master of Public Health from Harvard University, where his course focused on health and social behavior. He is interested in the public health approach to mental health issues, including suicide prevention. And today, Dr. Ng will be sharing with us his insights into the suicide and self-harm situation in Singapore. His talk will cover basic facts about suicide in Singapore and in general, and also highlight some of the suicide prevention interventions in Singapore. Without further ado, we'll begin the presentation. Dr. Ng, please.
Good afternoon, everyone. Welcome to this talk titled Suicide and Self-Harm in Singapore. My name is Jared. I'm a psychiatrist working at the Institute of Mental Health Emergency Services. This afternoon, I'll be sharing with you some of my readings, my experience dealing with suicidal patients, and some of my thoughts about this topic. I may not necessarily represent the views of MOH and IMH, and maybe some parts you shouldn't quote me because I do get carried away when I give this talk. This is not a clinical talk. In the audience, we have got very learned people with a lot of experiences with this topic as well, so I'm really looking forward to the Q&A at the end of this session. Suicide is a wicked problem. We may have seen this term nowadays, but what exactly is a wicked problem? It is a problem that is difficult or impossible to solve because of its complexity and interconnectedness. And you can imagine why suicide is a wicked problem. It is not a Singapore problem. I think the world is facing this suicide described as a public health crisis. Almost 800,000 people die due to suicide every year. And this works out to be roughly one suicide in the world every 40 seconds. Even though there's so many suicides, every single one of them is a tragedy. One recent US study suggested that for every one suicide, more than 130 people are affected emotionally, psychologically. So you can imagine the impact of suicides in the world in Singapore. SOS just published their data for 2021 recently, in July actually, and it showed that actually suicide numbers in Singapore, the total numbers have dropped from 452 the year before to 378, but the number of youth suicides climbed up. 378. If you look at this, every year the number hovers around 400. We almost always have 400 suicides a year in Singapore. If I were to ask you to guess about the number in 2022, as long as you say a number around 400, you won't be that far off. And of course, I hope this doesn't come and bite me next year when suicide numbers are released. But our suicide rate is dropping. We have a consistent numerator, 400, about there. But our population is increasing. So our suicide rate actually is dropping, and across the age group as well. Can we ever eradicate suicide from our society? Probably not. This Frenchman, of course, there's a lot of criticism about his book and about his study, research methods, and so on and so forth. But he predicted that there will be an increase in suicide during periods of major life or social changes. And this was published in the 1800s. Is there a time in our history where there will be no life or social changes? We are still in the midst of a pandemic, and all of us witnessed the effect that had on us, on the world. Durkheim also mentioned this, not in these words, but he mentioned this, that the more socially integrated and connected a person is, the less likely he or she is to commit suicide. And I think from clinical experience, I can tell you that this is true. I see patients in the emergency room who are suicidal, and many of them are socially isolated or disconnected from their family, from the community. An even more wicked problem then is youth suicide. I'm not sure how many of you in the audience are parents with young kids. I'm not sure how you react emotionally or psychologically when you read about kids taking their lives. I saw an 11-year-old in the emergency room not too long ago. The parents found suicide notes in her pencil case. I saw the notes, right? Pictures of it. And this 11-year-old girl wrote about how difficult and hopeless her life was due to the issues she was facing in school and at home. My son is 11. I didn't go and search his pencil case for suicide note, but certainly we had a father and son talk, right? About the stress he's facing in life and actually why people consider taking their life. Yeah, we have very, very difficult conversations at home, considering the father's a psychiatrist and the mom's a psychologist. Yeah, but it is a wicked problem. We have 37 young people who took their life last year. 2014-2015 was when there was a doubling of figures from 13 to 27. A lot of intervention strategies was devised at that time. Last year there were 37, it represents a tripling. We need to do more, and there's certainly things that we can do in future. But is this a new problem, young people taking their life? It's not. This article came out more than 20 years ago. I'm not sure how many of you remember this. A primary 4 girl took her life because she was unhappy with her schoolwork, unhappy with her mid-year exam results. So this is not a new problem, but it is a rising problem. Another wicked problem, if we think about suicide as a tip of the iceberg, then how about suicide attempts? 10 years ago, this article was published. I was a younger doctor at the time. I thought the numbers were a little bit too low. Since then, there have been reports, there have been published data about the number of suicide attempts in Singapore. If I average them out, it works out to be about 3 suicide attempts a day in the whole of Singapore. I probably see that number in one afternoon in one hospital. So this may be underreported. In 2020, the numbers tripled to almost 3,000. Is it because when suicide was decriminalized, more people decided to take their life or try to take their life? It's not. The data suggests it, but it's not. It's really about how data is being reported. And what's the issue? It's about reporting. So prior to decriminalization, data was collected from the police, and after that, data was collected from the hospital. I work in a hospital that probably sees the most number of suicide attempts. And I can tell you that we are trying very hard to get the doctors to be consistent in their assessment and their reporting. Right now, there are no rules, no regulations or laws stating doctors must report suicide attempt. We don't have a suicide registry, not like some other countries, right? And certainly reporting of suicide does have its consequences. We have patients who tell us not to put their attempt, not to put the diagnosis inside their discharge summary, for example. Imagine families, insurance companies being able to see some of this diagnosis of suicide attempt. There'll be consequences. So it comes down to our teaching, right? What I teach the clinician. When I teach them about self-harm and suicide, I'll tell them to look at intent. Intent is important in how you classify a person's injury, whether it's a self-harm or suicide attempt. You can imagine how difficult this is for the trained and even more so for the untrained. Coming to suicide, we know the science of it. We have got studies, we have got research in Singapore and from around the world. We know the risk factors for suicide. We know the triggers and source of stress that tips people off into considering taking their life. This is a list of stressors for kids or teens, a similar list for adults, and also another list for elderly who face unique problems as well. We also know the protective factors that keeps people from taking their lives. So what's so wicked? We know the science, we know the data. I think the problem is that this is extremely complex. There's an interaction of the risk factors and the lack of protective factors. You add in the stressors and triggers, could be acute, could be chronic. There are cultural factors involved, the person's religion, the spirituality, family factors. Different ones of us are vulnerable for different periods of time in our lives, and plus the availability of means. This makes this entire interaction very, very complex, and hence suicide prevention is really, really challenging. Some clinical issues. It's very difficult to differentiate between people who think about suicide, people who attempt suicide, and people who eventually take their life. We don't have enough hospital bed to hospitalize every single person who has suicidal thoughts. And despite having good medicine to treat depression, we have antipsychotics, we have mood stabilizers, we don't have an anti-suicide pill. We don't have that yet. I wonder whether we'll have that ever. A lot of people may think that suicide has this script, right? You think about, you want to die, you think about suicide, you have a greater intent, you plan your suicide and you take your life, but on the ground it's not like this. It's jumbled up. People can jump from just having a desire to taking their life, just like that. There is no pathway, there's no standard script to follow. And it's very important then for us to also note that suicidal acts are often done on impulse, and the crisis that triggers them are just very fleeting, if you remember the list I showed you earlier. And of course, what methods people use depends on what's available. So this is really a question that needs to be asked. From a person having a thought about suicide to actually doing the attempt, how much time do we have? Because this is really a time that we can intervene. This was a study done in Houston. They interviewed people who survived their suicide attempt. When this was published, it was alarming. Imagine you have less than 5 minutes to intervene for a quarter of the cases, and for 90%, almost 90% of the people, you only have about 8 hours to have some intervention. They replicated this study in another part of the US. Of course, there's a group on the right-hand side you can see that took time to plan, to think about their suicide attempt. But the majority, more than almost half of them, had less than 10 minutes. And this really demonstrates the importance of family members, the importance of caregivers, the importance of friends, and the importance of first responders and suicide crisis hotlines to help. Clinicians may not be able to be so useful for this group that's so impulsive. The other issues that we may face, warning signs. We talk about warning signs of suicide for a long time. You can type into your search engine, Google, warning signs of suicide. And when I did it, there were 28 million results. These are wonderful efforts. When I give talks about suicide, I also teach about warning signs. But warning signs cannot be the only method to pick up who is suicidal. This is an unfortunate event that happened in the US not too long ago. You don't need to read through this, but I think the reporter tried to say that there were some warning signs. But does it mean that someone who is bullied in school, who gets into fights in school, who stops attending school is going to end up being a killer? No. Just as people who talk about wanting to die may not end up taking their life, it is very difficult to just use warning signs as a method to identify who will eventually take their life. It is a risk factor, a very important risk factor, but it can't be the only thing that we use. We can prevent suicide by design. It is not just doctors, but design is important. And this comes with it. Why we talk about it is because of means restriction, and I can tell you why it's not so easy in Singapore. Before the 1960s, people killed themselves by hanging. Since the 1980s, jumping from heights is the #1 method because high-rise buildings are freely available in Singapore. How do we restrict people's access to high-rise building? It's difficult. We have done something and it's successful. I put over inverted comma, not because I'm skeptical, but I agree that it's successful. Some of you will remember days gone by where there was no barricade. Now there is, and this helps to prevent a lot of suicide. We have got these barriers at the top of MBS. Now suicides certainly still happen. We have a 2-meter high screen, but interestingly, I saw a report that says that in Switzerland, the barriers should be 2.5 meters and tilted towards the center. You can see how they use design to stop suicide. Suicide risk assessment is important. A lot of times we think of suicide risk assessment tool as something like this. This is for heart disease. You enter some data, some random data, and it tells you that you have a 13.435% chance probability of having a heart disease. Can we enter suicide risk factors into a tool and tells us the chance that this person will kill themselves in the next day, the next 1 week? We don't. It's a very imperfect science. A lot of false positive, the tools, there's no perfect tool. It's valuable if patients are truthful. We know that some of them are not. There's many tools in the market. I'll very quickly show you. They have the SET% tool, you have a PHQ-9, you have a CSLRS, which is very commonly used in Singapore. But we must know we cannot just use one single tool in isolation to determine risk level. So what can we do about suicide prevention? There's many measures. I don't have time to go through them all. I'll very briefly talk about the media. Right. The media plays a big role. We know that during this time there were a series of copycat suicide from MRT track and Bedok Reservoir. So media needs to be responsible when they report suicide. Will the person seek help when they read this article? Social media is important. Everyone uses smartphone in Singapore, have access to social media. There are benefits. I am not going to talk about the benefit of social media. All of us here are on social media, I think. But internet comes with risk. YouTube features people who harm themselves. people are bullied online, there is social isolation, there are unregulated content. And these are things which I think as parents, as the community, we need to be aware of. And then what is there a role then? Let's try to harness the role of social media then. What can we do? We cannot stop people from using the internet or using social media, but we can certainly think about how we can harness social media to do suicide prevention work, to talk about suicide and how to help others. So I'll leave it with this slide. It talks about the importance, this poem talks about the importance of building a fence at the top of the hill, then to have a fleet of ambulance down in the valley. And I'll be very happy to answer your questions and have a discussion.
Thank you, Dr. Ng, for the thought-provoking sharing. The presentation has certainly led us to think further about the issue of warning signs, how it is an important risk factor, but should not be the only method to identify who will eventually end their life, and the issue of suicide assessment, which Dr. Ng described as an imperfect science. And I personally resonated with Dr. Ng's point about how suicide, especially youth suicide, is a wicked problem because of how complex it is. And we note that there was a comment from the audience that many of us would agree with. It is regards to how it is not easy to discuss about suicide with our own children. So thank you, Dr. Ng. The last presentation we have in this special session is by Ms. Khairia Kasim. Ms. Khairia is a good friend and colleague of mine. She is a lead psychologist and head of operations and resilience psychology branch of the Emergency Behavioral Sciences and Care Unit of the Singapore Civil Defence Force. She holds a postgraduate degree in clinical psychology and spends the first decade of her career as a prison psychologist, accumulating over 12 years of clinical experience serving clientele population from various culture, education, and work background. Khairia's current work areas include promoting psychological resilience for frontline and staff units through preventive and intervention approaches such as training and the provision of counseling services. She's also involved in the planning, management, and provision of crisis interventions for SCDF personnel who were exposed to high stress turnouts in their line of duty. In this presentation, Ms. Khairia will share on the impacts that operational stress can have on emergency responders' mental health and the Singapore Civil Defence Force approach in managing operational stress in supporting their personnel. She will also use 2 case studies from supporting frontline emergency responders in the Singapore Civil Defence Force to highlight how acute stress reactions can manifest and still be managed adequately. Let's now begin the presentation. Ms. Khairia, please.
Good evening, distinguished guests and colleagues. I'm Khairia Kasim, lead psychologist and head of operations and resilience psychology branch from the Singapore Civil Defence Force. Today, I am honored to share with you insights into operational stress and trauma for our emergency responders. This presentation aims to provide a dual perspective of how operational stress can manifest and still be managed adequately from the perspectives of a clinical practitioner and survivors of acute stress using case studies. Emergency responders are faced with challenging and potentially draining situations in the course of their duties. Rendering emergency support to the survivors and victims, while necessary, can put them at an increased risk of trauma. Emergency responders may experience a myriad of symptoms associated with acute trauma stress reactions due to the nature of their work, such as intrusion, avoidance, hyperarousal, and mood fluctuations. Individuals can experience cognitive and emotional reactions, which can also contribute to strained family relations. It can also increase the risk of development of more severe forms of psychological disorders and prolonged acute trauma stress reactions, which could also lead to a diagnosis of PTSD. Due to a heightened level of psychological symptoms, the morale of teams can be affected. For example, social withdrawal that are possibly experienced by affected personnel can result in reduced communication, increased potential conflicts, and overall reduction in team morale and operational readiness. The exposure of critical incident stress doesn't just affect the individual. At an organizational level, it affects overall morale, job satisfaction, and turnover rate. That is why the management of frontline job stress, especially for those who are, or rather, especially those who are more exposed to unprecedented calls and ops, is crucial in our work. The frontline job our colleagues are involved in has its risk. Abbott and colleagues' study in 2015 estimated that 30% of emergency responders develop behavioral health illnesses, including but not limited to depression and post-traumatic stress disorder, as compared to 20% in the general population. In another study by Lewis and colleagues, found that ambulance personnel develop PTSD at rates ranging from 9 to 20%, 22%, and firefighters at rates from 17 to 32%. This contrasts with approximately 7 to 12% of adults in the United States that will develop PTSD at some point in their lifetimes. So how does this look like on the ground? A personnel is trained to look out for signs and symptoms of stress. However, when an unprecedented chain of events occur in the line of duty, a critical incident may occur and the officer experiences extreme stress which overwhelms his or her coping strategies. This operational stress therefore invites an experience of acute stress as he or she responds to a traumatic event. Over the course of a month since the onset, the individual then experiences symptoms of intrusion, avoidance, hyperarousal, and mood changes. And when these symptoms remain unaddressed sufficiently, the experience prolongs and could lead to a diagnosis of PTSD. So what then do we look out for in minimizing the psychological and behavioral responses and trajectory of distress? The clinical definition of peritraumatic distress is a subjective sense of numbing, depersonalization, detachment or absence of emotional responsiveness, and an alteration of awareness of one's surroundings. Such peritraumatic distress reactions are taken into consideration in predicting adverse mental health outcomes following trauma exposure. And if the operational stress and peritraumatic distress is not addressed sufficiently, emergency responders may find themselves struggling with mental health issues. This could involve distress responses such as irregulated sleep, distraction, isolation, and decreased sense of safety. Over time, officers may experience psychiatric disorders and possibly engage in health risk behaviors that may affect their overall well-being. Presence of PTSD in emergency responders itself has been found to be related to reduced quality of life, poor physical health, more medical visits, and more suicidal ideation. Thus, early interventions are vital, as adverse mental health outcomes may contribute to adjustment problems in social, family, and work setting. SCDF employs a holistic approach in managing the operational stress of personnel. Psychological resilience training and support is provided at pre-deployment stage. During deployment and operations, we continue to provide psychological support for major operations and exercises. Group and individual follow-up are also provided for those who may be affected due to the exposure of critical incident stress. Not just that, SCDF provides a 24/7 counseling helpline, and we built our network of SCDF prayer counselors made up of regular officers and national servicemen full-time support network. In-house psychologists therefore play a vital role in the management of acute stress among frontliners. It is within our expertise to differentiate the nuances in the psychological and behavioral presentation through clinical judgment, and then propose and effectively implement relevant interventions to enhance recovery and post-traumatic growth for these individuals, minimizing undesirable mental health disorders. Let me share with you about Matt and Darren. They are our in-service officers who have provided their consent to share about their stories and experiences with operational stress. Their names have been changed for the purpose of this sharing. First, Matt was my client in 2021. He is unmarried and had no romantic partner. He had an uneventful history and did not present any significant concerns in his work as paramedic in the past 3 years. He completed all relevant trainings and performed his duties diligently. He signed up for the job as a full-time paramedic to save lives and was aware of the nature of the job. In his 3 years of experience, he had responded to various types of calls, including deaths of his patients on arrival and patients who had also succumbed on their injuries subsequently. 2 weeks prior to our meeting, Matt attended to a call to respond involving a toddler. Toddler was assessed to be responsive upon his arrival. The ambulance reached the accident and emergency department, and Matt handed the patient over to the hospital staff. He walked away briefly and then came back to hand over the necessary documentation. But just as he opened the curtains, one of the staff stared at him hard. the staff was resuscitating the child. Matt handed over the file, left the scene, and started pacing up and down near the ambulance. His colleagues asked what happened. He started talking fast with his hands shaking. The scene was shocking for him, out of his expectations, but this was not mainly because the child was involved. The distressing scene for him was the stare of the other individual, and in Matt's perception, it felt as though he was blamed for the child who went unconscious in his absence. So Matt persevered after the call. He went on to his own routines, but he knew something was wrong. Shortly after the incident, he started experiencing flashback, manage the anxieties, and to continue his work as a frontline. So I saw Matt for a couple of sessions. He was a willing party to reduce distress levels through the use of psychological interventions with me. In the first 15 minutes of our sessions, his hands were trembling, his speech rate was rather fast, and I noticed how he tried his best to maintain his composure, but still very much in a hyper-aroused state. The rapport building was necessary for Matt to experience sufficient psychological safety so that he could disclose what had happened without the fear of being judged. We worked on relaxation strategies to manage his arousal state first, worked on relaxation strategies such as deep breathing. This was necessary to allow his rational mind to slowly come into the session. Then once it was calmer, he revisited his traumatic memory, and of course at this time, Matt left out many details of the event. We had to go slow and sequence the chain of events well enough for my own understanding. And using a Likert scale, we identified his most distressing scene, which was about the other party looking at him in the eye. And at this stage, his anxieties heightened, and relaxation strategies had to be practiced again in session. Subsequently, we worked on making sense of the experience, finding evidence to why he could possibly have felt that way, and using evidence to challenge his unhelpful thoughts as well. This was done with caution, and equipped with the necessary skills and knowledge, it was important that Matt felt safe to share his inner thoughts and emotions. There was a lot for Matt to work on between our sessions. At the supervisory level, we also worked on providing the psychoeducation on symptoms and management of operational stress, as well as providing him with the necessary handholding and exposing him gradually back into the front line. As a result, Matt's symptoms on the psychological screener a week apart indicated a very quick decrease over his depressive, anxiety, and stress symptoms between the two brief sessions we had, similar to what I had observed in my session. His motivation to address his issues enabled the session to go smoothly, such that he was willing to consider alternative thoughts that were more helpful for him to believe that he has done his best in the situation he was confronted with. More importantly, Matt, he strengthened his social support by tapping on his colleagues and supervisor. And then there was Darren. Compared to Matt, who had signed up for the job, Darren was a client who was serving his national service. He was in his early 20s. He was serving the nation as part of the 2-year requirement by the Singapore government. As compared to Matt, he did not sign up for the job and did not have any prior experiences. Darren was referred by his supervisor due to his reactions after responding to 2 back-to-back calls. It was his second duty as a frontliner. He and his team were responding to a call as a patient had needed help for a back pain. His patient, however, had collapsed in front of him after suffering from a cardiac arrest. Despite his team's best effort, the patient did not survive. In the second call, immediately after his team reached back to the station, it was another cardiac arrest call they had to attend again. Things were messy, Darren panicked, and he did not know what to do. He had lost focus and ransacked the work item and could not compose himself. This time, the patient survived, but he kept apologizing to his team. So Darren began doubting himself, questioning his competency. He feared for the worst-case scenarios every day before his shift. He became more and more anxious, had difficulty sleeping, and his mood was affected. He could not stop himself from experiencing disturbing thoughts, and his self-confidence went downhill. My experience with Darren was unique. We had 2 sessions over Zoom due to the COVID-19 situation. This was a challenge for me. During our session, Darren appeared slightly worried. His narratives were full of what-ifs. What if I'm unable to perform during my next duty? What if I were a burden to my team? I tuned to the frequency of his voice and the subtleness of his anxieties. So to work with Darren, it was important to revisit the events again and identify the common theme and unhelpful thoughts that made him worried for his calls. Suicide risk assessment was also conducted, and providing the necessary education on his symptoms when necessary. We focused on equipping him with the necessary skills with involved deep breathing during our session. Similarly, we worked with his supervisor closely. The combination of both individual and operational level interventions helped Darren to continue to cope with the demands of the operations work. In his narratives, Darren also shared the following. If I know a case is quite bad, it's going to be urgent, I'll feel a sense of panic, and that's when I'll start to apply these techniques, which I'm still using up till today. I have a clearer mind, I'm more composed. On the way, I'll do the breathing techniques. Through Darren's case, we learned that these skills are useful when it is incorporated into the work routines. And that we learned that it is not a case where acute stress goes away immediately, but it is more about growing with the stress and handling with the stressors when they come. Through these case studies, we identified that the frontliner's perceptions towards the most distressing moment had contributed to the acute stress, and this was therefore an important element that we worked on during the sessions. What was helpful was indeed their motivation to recover and grow from their experiences, regardless of whether they had signed up as a full-time officer or just serving their national service full-time. In short, the elements of the TFCBT was used to manage the acute stress reactions of Matt and Darren. This is supported by multiple studies in various contexts. For example, Brian and colleagues studied patients diagnosed with acute stress disorders within 2 weeks of onset and found CBT resulted in greater reductions in intrusive, avoidance, and depressive symptoms compared to supportive counseling. While pharmacological interventions can be helpful to minimize the physiological reactions, its effectiveness can be limiting. Hence, in this case, psychotherapy is important and essential for management of acute stress reactions. That is not all. These two individuals would not have grown from their experiences if not for the perceived supervisory support and close partnerships between the psychologists and the supervisors. In the Singapore context, and the in-house psychologists can work with supervisors directly to help our frontliners return to normalcy. For practitioners among us, this means that being able to have clients like Matt and Darren go through gradual exposure as supported by the supervisors. We work closely with Matt and Darren's supervisors by explaining to them about what gradual exposure is in layman's term, which is to slowly expose and re-expose the client to the nature of the job and work in tandem with them to ensure that the symptoms are managed sufficiently. In our experience, supervisors are willing parties in the equation. Supervisory support is key to one's post-traumatic growth. In summary, the stories of Matt and Darren elaborates on the acute stress reactions that they had experienced in their operational work. There are two main levels that we worked on, first at an individual level and second at an operational level as following. While Matt and Darren's cases illustrate the successes of interventions through the individual and supervisory level, this presentation has some limitations that require further considerations. First, casual check-ins with Matt and Darren revealed that they have been coping and is still in the front line. It can nonetheless be helpful for us to continuously track their symptoms through post-intervention follow-ups. Second, perhaps it could be helpful to explore the relationships between the different mental health-related markers and the different types of operational stress. For example, which symptoms are related to the acute stress, and if these symptoms differ from an individual experiencing prolonged exposure to trauma. In future, we could also explore other forms of treatment methods to help our frontliners in individual setting, such as the use of eye movement desensitization and reprocessing techniques, and to compare and contrast with the TFCBT approach. Moreover, advancing our research to enhance resilience for frontliners can be explored using technologies. Through this presentation, I hope that we have been able to identify the role of practitioners in public service in supporting frontline work, highlight that psychological interventions can have desirable outcomes if conducted at the individual and supervisory levels. Also, I hope this presentation exemplifies the importance of collaboration and strong partnership between affected individuals, supervisors, and practitioners. Finally, the exploration of various modalities and also advancing research can also potentially enhance resilience for our frontliners as we continuously improve on our mental health services and to contribute to the scientific field of emergency responder services. Thank you.
We thank Ms. Kyria for the interesting presentation. I believe many in the audience have benefited from your sharing, particularly on the case studies you have shared, allowing us to learn how the mental health of our emergency responders are also being put on the line when they turn out for calls where a life is at stake. You also highlighted how the individual and supervisory levels of symptom management are essential in promoting post-traumatic growth. I particularly like the point about the use of continued skills practice, such as breathing techniques from the case study of Darren, as it is a strong reminder to all of us that the pursuit of mental health and well-being is an ongoing journey. We have come to the end of this special session and will now be moving on to the live Q&A segment for the remaining duration of the session. We also like to invite the presenters into the virtual space for the Q&A segment. Hi, Dr. Hi, Jessie. And now we're waiting for Ms. Kyria. All right, okay. So from the Q&A tab, you will be able to see that this special session has indeed garnered the interest of many of our audience based on the number of questions coming in through the Q&A. So in no order of preference, perhaps I can get the ball rolling with this first question for Dr. Ng. Okay, so there's this question on preteen suicide. So cases of preteen committing or considering suicide is chilling. How do you suggest we talk to children about suicide, given that we may not have training in child psychology? Dr. Ng, will you have any thoughts to share on this question?
Yeah, I think this was probably in response to what I said in the pre-recording. Actually, when dealing with my kids, me and my wife, we make a conscious decision at home that we are not mental health professionals. We are parents, and otherwise it's very stressful to be my kids when they have to be examined by their parents all the time. But I suppose we do utilize some tools of the trade, like practicing active listening. We don't get emotional. We don't interrupt the kids when they're talking to us. But I think beyond that, it's really about spending time with your children, having conversations about everything, not just about academics, not just about mental health issue or suicide. A lot of the news nowadays show up in social media or in the newspaper. May not be the front page, but we are always encouraging the kids to read the newspaper, right? They show up. Even if me and my wife choose not to talk to the kids at home, they are going to be talking about it in their school bus, in their school canteen, in their classroom, in their WhatsApp chat group. And a lot of it, when I look at my son's chat group, right, it is not right. You know, the context is sometimes all wrong. And I think as parents, we need to provide certain context. With regards to suicide, I think my kids are immersed in it because they hear me do presentations about suicide all the time. So it's a little bit easier for me, but I will ask them what do they think, what are they facing, what kind of stress that they are facing in school, why do you think the person did this and did that, how can they cope better. Then obviously we'll sneak in a question of, if you go through difficulties in school, who are you going to talk to? Is there someone you can talk to? And then we see what they say. So of course, I have 3 kids, different ages. We talk about it. We use different not techniques. Sorry, I'm not a mental health professional at home. We use the language that caters to their maturity and their age, and we try to do it separately. So I may take the kid out for ice cream, and then we start to talk about life, right? And that's where we bring up some of these things about stress. Yeah, I hope that helps.
Thank you, Dr. Ng. So the key point is really to clarify our roles at home, not to put on the psychologist or psychiatrist hat when we are interacting with our kids. And I just wonder, knowing Kai's work in SCDF, I wonder whether she has any inputs to share on this point about how to talk to children about suicide.
Well, I'm a parent myself too. I have 2 very young children. I think first we need to acknowledge that it is a difficult topic. It can get difficult because you're also mental health professionals outside home setting. So similarly, like Dr. Jared, it's something that I try my best to allow myself to be a parent first. And I will definitely make mistakes in my parenting for sure. So it's important for us to be good enough parents to acknowledge that we have limitations. We have our strengths and weaknesses, and we'll just do our best to talk to our children with regard to suicide. So I think for now, what I do at home is to actually ensure that the bond between me and my children, or my husband and my children, still happens. This is very important because we need that rapport for our children to be okay talking about difficult issues with us. I think being in a mental health profession itself also exposes us to a lot of it's a professional hazard to some extent, because you're always going to worry about certain things that come along the way. Issues, or you are afraid of hey, is this something that I really need to be careful about, and things like that. But I think what's more important is to provide that listening ear, to allow ourselves to make mistakes, or rather to be good enough parent and still to learn more, to learn about how to parent well, talk about suicide if it's necessary, slowly talk about it. If they ask a question, I'm still learning myself. I have no standard answer for this, to be honest, Young. Yeah, so it's not easy. I'm struggling to some extent. But I think what's more important is to build that rapport with our children first, on a daily basis. Yeah.
All right, thank you, Khairiyah. I think it's really normalizing for all of us to hear how we also struggle with our own children. I think parenting is definitely an ongoing learning journey for everyone. Okay, so moving on, I'm mindful of time. So moving on to the next question is actually from Miss Jessie. So Miss Jessie, your sharing were based on interviews with people who subscribe to religions. So we wonder whether similar results could be expected among individuals who are agnostic. So for instance, people who are spiritual but does not follow a particular prescribed religion. So I guess the intent of this question is really to understand if the effects are moderated by having easier access to social support through religious organizations.
Thank you, Swee Kyung, for the question. I think that, as part of this study, we were actually able to interview some that identified as spiritual but does not follow a prescribed religion. Although we ended up not including the results here because spiritual coping and religious coping is defined slightly differently in the literature. But my quick answer is that based on what I've seen and also in the literature, they would share some similar elements. And this could be, for example, acknowledging that there is like a higher power or a higher being in their appraisal of the event. And for people who are spiritual but do not follow a prescribed religion, they also obtain social support from other different channels, such as family and friends from within communities that they are involved in. So yes.
All right, thank you, Jessie. So we do have time for one last question, perhaps a quick one. Okay, so for Khairiyah, which model for critical incident stress debriefing do you use? And can you tell us a bit more about what Moral Sensing for National Day and F1 involves?
Okay, so the critical incident stress model that we use is actually taken from the International Critical Incident Stress Foundation, ICISF for short. So this is something that we adhere to, and I believe within the Ministry of Home Affairs in Singapore, we also subscribe to this model, this framework altogether. With regard to the moral sensing, during NDP and F1. So basically, we conduct a sensing of the factors that could contribute to their operational stress during deployment, especially during NDP or rather National Day Parade and F1 altogether. So this would then be highlighted to the senior management to help improve conditions to ensure operational readiness. We also measure the confidence level of our frontliners to ensure it's mainly to improve and maximize operational readiness altogether.
All right, thank you, Khairiyah. So I do have more time, so I guess I can actually ask more questions from the Q&A. So this question is for Khairiyah again. Sorry, I didn't give you a time to breathe, to have a breather. Okay, so this question is, how do you balance the need to maintain confidentiality with your clients while involving the supervisors in interventions?
Yeah, that's a very good question. The need to maintain confidentiality is something that we try to uphold as mental health professionals for sure. Depending whether it's supervisor referred or self-referred, it's two different issues. But regardless, if let's say it's supervisor referred, then our supervisors actually have to fill out the counseling request intake form altogether to request for a counselor to see the personnel affected. So we would actually try to get or rather gather corroborative information, hear the concerns that the supervisor has, and the goals that supervisor hopes to achieve by having the client be referred to us altogether. Once that's done, where we see the client, where of course we have to do what we need to usually do, our intake interview, etc., and to really find out his counseling goals, etc. The amount of information that we provide to the supervisor is usually checked in together with the client himself. We don't tell A to Z. We don't provide a report stating A to Z, but it actually follows quite a standardized psychological update via email to our supervisor. And not just that, we also provide at times recommendations of what the supervisor or the station can do to provide the additional help for our frontliners to ease back to normalcy after being affected by some level of operational stress altogether. But of course, if there's certain issues that we need to raise the supervisor, this is usually covered in our confidentiality clause, the usual, if there's a risk of harm to self, others, or the organization. Of course, this is something that we still adhere to. But if let's say details like, family issues and things like, if it's not relevant, we will definitely not provide. It also is based on our clinical judgment altogether. Yeah, most of the times we are supervised. Actually, we are very much supervised in our work. So if we do have any issues or we face with certain ethical issues along the way, we would always check in with our supervisor, commander of the unit as well.
All right, so definitely quite a fair bit of discretion is needed when responding to the supervisors when they ask for information. Okay, so I have a next question for Dr. Gerald. So it's a pretty long question. Okay, so from your experience, what is the advice you would give to law enforcement or social workers after first response? So in terms of first response, they were referring to people after they have attended to people who attempt suicide. Yeah, so quite often the person in need is handed over to another agency or hospital. So the person who asks is actually wondering whether it's a good idea, for instance, for social workers or doctors and the police to come together or the FSC to come together to work with the families to help the person who was suicidal. So in practice, the person actually see them thinking their roles are different and so don't really need to exchange notes or work together. So do you have any experience where professionals work together help, and whether there were times where it was actually counterproductive instead?
Yeah, okay. Thanks for the question. I think we really started a crisis response team, which is manned by mental health trained counselors and nurses ever since, I think, a year plus ago, really to support the police who encounters persons with suicide risk. So the police is the first responder. I think they are really important because they are really everywhere and they can respond very quickly. And then they will assess the suicidal individual first, and then they can actually call a dedicated number to the service, the crisis response service. And then the nurses or the counselors would then have a chat with the police to find out what's going on. And they could talk to the person, the suicidal person, and also talk to the family to do a quick phone-based assessment. If that is enough for us to assess the case as high risk, then we'll advise the police to convey the patient to an hospital for further evaluation. Certainly, if there's a need for us to deploy nurses on the ground to go to the police straight away, we can do that also. Of course, our response time is not as fast as the police. Will probably take about 20 to 30 minutes to reach where they are. And then we can do an on-site assessment to see what is the follow-up action. I do agree that working together is extremely important. I don't think there's many downsides to it. Our department is new, actually, since January this year. So I'm trying to make sure that all the team members practice this thing called warm handoff, meaning that it's not enough to just refer a patient. We should talk to an agent of the other party, the one they refer to, whether it's a community partner or whether there's a mental health professional on the other end, so that we hand over the case properly. Certainly, this requires consent from the patient. There are patients who come to us and they will refuse for us to talk to anyone else. And therefore, we can't share any information if the patient tells us that we can't share. How much continued interactions among all the parties really depends on the patients, the clients, and the diagnosis, right? There are some cases which is, I think we just see them one time, two times, and that's it. They actually get on with their life and they can cope. Sometimes there are patients who continue to have a lot of difficulties and repeated crises in their life. Then we may have multi-agency conferences where we don't just involve the mental health professionals. Sometimes police are called in, town council, HDB, sometimes NEA is also called in. So I think it really depends on the individual case for us to pull the right people in to solve the problem for the patient, so that we don't see the patient as the problem. We try to solve the patient's problem instead. So I think we are trying very hard to do that. So if there's grounds for us to improve, please feel free to let us know as well. Yeah.
I think this also links back to what you mentioned about suicide and how it's actually a wicked problem, because it's really complex and it does take many people and stakeholders to come in together to support one who is suicidal. Okay. And I have a question for Ms. Kyria. In your experience, is group session useful for facilitating recovery among emergency responders?
Thanks for the question. So what we do at SCDF is that we employ the ICSF CISM approach altogether. So we actually have, we conduct critical incident group debriefing. If let's say our commander fire station see the need to activate my unit to actually help to have the frontliners sit together, process what has happened through a very structured approach using the CISM framework altogether. So that's one example of how we do group debriefing altogether. So that is an example of a session where hopefully it actually helps to facilitate the recovery among our emergency responders altogether.
Okay, thank you, Kyria. Okay, there's a question for Kyria again. I guess a lot of people are interested in emergency responder mental health support. Okay, so this particular person is interested in your engagement in TF-CBT during the first month before PTSD is even able to be diagnosed. How soon after the traumatic exposure do you start? Is it as soon as you see evidence of negatively impacted cognitive functioning or other acute stress symptoms?
Okay, thanks so much for this excellent question, actually. It's not an easy question, to be honest, because for us to really know when to step in, I think there needs to be a balance between allowing natural recovery as well as seeing whether that presentation is slightly subclinical to some extent. So how do we get there? How do we come to that balance? It's usually done, of course, through your clinical experience, your clinical judgment, and kind of have a sensing of what's really going on. In this line of work, I have to be honest that we can't do things independently, such that our mental health professionals usually work in teams to really identify whether this is somebody that we need to really see ASAP or not. In some situations, for example, if it was a group session, we realize that someone is very affected, we'll continue to monitor the person for about 4 to 6 weeks. But if you see through the case studies of Matt and Darren, it was the case where it was very individual, at a more individual level. They experienced symptoms that they realized that, hey, something is a bit off, so therefore they need to see us. So on this note, then, based on my experience, and I have seen clients with presentations that, or rather they come in within 2 weeks since the onset to about a month or so. And you could actually see how using a clinical approach could actually help when the client actually comes to us at their soonest. So it's not which is better, in my opinion. I think it really depends. If there's group sessions, then of course you're using the dynamics of the group and the shared experience all together to help facilitate that recovery. But of course, if it happens at a very much individual level, then the earlier the person comes in just to do even just a check-in, that could actually be helpful. I would take a more precautionary approach. It's better to be safe than sorry. So sometimes we may actually, or rather clients may have the tendency to pathologize themselves, or even, kind of like, just dismiss their presentation altogether. So it's important for them to always do a proper check-in, proper assessment, and not just go on Google and just find out what's happening to me and then just take on that approach that I can recover myself. Yeah, so it's really very important to also, look into the help-seeking behavior as well.
All right, thank you, Khairya. So it's pretty much like how our ambulance goes out for calls, right? When it comes to crisis or trauma, time is of essence as well. Okay, so we have a last question for Dr. Jared. Okay, so this question goes, in the absence of statistics, would it be right to assume that the rate of suicides has increased over the years? And is it true that victims are more vulnerable currently? If yes, any clinical research or data on the reason of such vulnerability?
I assume the question is about Singapore. So actually, Singapore's suicide rate, we do have statistics. It's actually coming down, sort of plateaued a little bit. So at MOH, we certainly look at more specific data sets, like based on gender, the age group, ethnicity, and so on and so forth. So we do have data, and I can tell you that suicide rate is coming down for most groups. I can't tell you which group it's not, but for most groups it's coming down. But we need to know that all things considered, the number of suicides and even the suicide rate for Singapore is not high. So we do see fluctuations even with small little changes in the data. So I think that is important for you to know. What do we think that people are more vulnerable? I think one big area of concern is really the youth suicide, which I spoke about during the talk. Why are young people taking their life? And when I say young people, it's really 29 and below. Why are young people taking their life? And this seems to be more pronounced compared to other years, other age group. This is also a problem, not just in Singapore, but in other countries. We are in the midst of doing such research about why this is the case. One very easy target to blame is social media. That's why I talk a little bit about it, because a lot of patients who come and see us, even in clinic, anecdotally, I'll tell you that they tell us about social media. In fact, just a couple of weeks ago, I saw a girl who wanted to take her life because she was banned by Instagram for buying followers. I am not young anymore, so I have no idea what is buying followers about. But being banned from a social media platform made her want to take her life, and she was pretty close to doing it. And she was telling us during the clinical consult that her entire self-esteem and self-worth is based on the number of likes that she has. And her parents don't know what to do with her. So this is a very difficult topic, and we are still in the midst of looking at it now. Yeah.
All right, thank you, Dr. Ng. It's really not easy when we talk about youth suicide and the impact of social media on all of them. I think not just for youth, but in adults as well. Okay, so we have come to the end of the Q&A session. Thank you everybody for your enthusiastic participation. I would just like to invite everyone to join me in thanking our presenters for sharing with us their insights and research. I'm sure all of us have gained much insight into mental health, specifically on suicide crisis and coping during this session. Next up, we will be having a 2-hour break. We will resume promptly at 8 p.m. Singapore time. This might be a good time to check out the interesting range of asynchronous posters and paper presentations that we have for you. These posters and presentations are accessible on the sidebar throughout the whole conference for your viewing in your own time during ACOP 2022. We will also be presenting an award to the top 5 favorite posters on the last day of the conference, which is tomorrow. Hence, do remember to vote for your favorite posters. The online voting will close at 12 noon Singapore time tomorrow, which is 21st July, Thursday. The 5 winning posters will be announced at the closing ceremony. At the same time, please also enjoy the videos that have been prepared by the ACOP Organizing Committee. It's an exciting video series called Inside Out, where we hope to give everyone a sneak peek into the different areas of work that home team psychologists are involved in. For today, we'll be featuring our work in industrial organizational psychology and crisis support. After the break, we will have a keynote address. For today, the keynote address will be presented by Dr. Yunei Cho. we seek your understanding to rejoin us on this platform 10 to 15 minutes before the keynote presentation starts at 8. Thank you very much, everyone.
Hello everyone. Hi, I'm Shimin. I'm the Commander of Emergency, Behavioral and Sciences and Care Unit in the Singapore Civil Defence Force. So I oversee a team of about 13 to 15 psychologists and also uniformed officers who look into the psychological and mental health well-being of all the officers in SCDF.
And my name is Eunice. I'm a principal psychologist with the Home Team Behavioral Sciences Centre, overseeing the branch that looks at operations and leadership psychology. We're here today to share with you more about IO psychology in the home team context.
Okay, so today we'll be answering some true-false questions about IO psychology in the home team. So let's see the first question. Okay, so IO psychology work is the same as HR, true or false? False.
False.
Yeah. So I think in the home team, we work very closely with our HR colleagues. A lot of times in areas of people assessment or people development. So for instance, in people assessment, say when recruiting people, promoting people, or selecting people as leaders, a lot of times they will actually come to us, and what we value add is actually in terms of, say, for instance, administering certain tests on qualities, characteristics, values, or even attitudes that they may be interested in. Okay, and then what we do is that we actually find appropriate tests or appropriate methodology to help them assess for these areas, and then they will then take that and help in their assessment process in selecting the right people for the job. And then I think the second area is actually in terms of people development. So in people development, a lot of times we may actually work with them very closely to understand what they want to actually impart in, for instance, the leaders or the talent pool that they have. Okay, so maybe Eunice, you want to share an example?
Yep, so I think for us, psychologists may come in to help with some of the development work for our leaders and talent in the organization. So, for example, we may do psychological debriefs in terms of giving feedback based on psychological tests, say personality or stress coping kind of strategies. So we'll walk through with our leaders on these profiles and also have a conversation with them how this ties in their work behaviors and how they could enhance these behaviors further, for them to be effective at work. Yeah.
Okay, so the next question is, IO psychology work is desk bound, true or false? Nah, definitely false.
I did walk around for my lunch today.
What did she say?
But still, no, we're not desk bound at all. We talk to people, we interview people a lot, and what happens is we run assessment centers. So when we run assessment centers, we are literally running around, okay, across the different sites and exercises. And we do a lot of training, so we walk around, we talk to people, we share, we do sharing, So a lot of times, no, we are not at our desk. So if you send us emails, nah, we're not going to reply instantaneously. Sorry.
So a lot of my work involves training leaders as well. So that means I have to go down to the workshops to actually conduct it face to face. And I think that's part of the exciting part of the work because you get to meet different leaders of different levels from the organization. Yeah, so you also get to hear experiences. So I think these are the parts that take us away from our desk, which are pretty fun. The question is, IO psychology work is not as exciting as the other fields, such as forensic or clinical psychology. True or false? Definitely a false. Well, excitement is in the eyes of the beholder. So I think people working in this field, we have our own way of seeing interest and excitement from the work.
Yeah, so I think actually a lot of times, right, I think for psychologists, when we join as psychologists, we don't naturally gravitate towards IO psychology. People tend to think that, oh, clinical sites are more exciting, forensic side is more exciting. But actually, usually we are able to attract people over time. Okay, and I think what interests us, of the work, right, is actually a lot of times you actually are going beyond the individual. So if you do certain case or if you do certain counseling, for instance, it's very individual based, and you're trying to tackle problems, of what that situation is presenting. But I think for our psychology it's a bit different. We tend to be a bit broader. We still do work at the individual level, but it's for the purpose of the whole organization or for the whole team in that sense. So in that sense, we are hoping, say for instance, to make sure that we select the right workforce for the whole organization. We're trying to develop the whole leadership team for the organization. And so in that sense, our work is much more beyond the individual. And at the same time, what we are trying to do, it may be more positively framed. A lot of times we like to see what is this ideal state that we are looking for, and therefore then we'll maybe work out certain things, or certain projects, to make sure that we actually reach what we want to achieve for the organization.
I believe we've come to the end of the true-false questions, and we have a couple more questions to answer for the last part of this session. Okay, so what is the biggest challenge that we've encountered as an IO psychologist? I would say for me, a pretty common challenge that I have seen across the years that I've worked so far is really about balancing rigor with the organizational needs. So what I mean by that, for example, we do want to ensure that a program or exercises that we develop and design are of a good standard. They are relevant, they are suited for the needs. So we do want to spend time validating or ensuring that accuracy is there, making sure that the details actually suit the needs of the program. But of course we do not have all the time in the world. So there's a certain timeline to follow. So we do have to ensure that we deliver within the timeline. So we have to balance the rigor versus the needs and the timeline. So this is something that oftentimes we come to struggle with, but we also come to get the hang of it over the years. You come to see that these are things that you do have to come to a certain win-win situation to see what is a good enough program and level of quality to deliver. So you still keep a certain level of rigor, but you also deliver the organizational needs.
So what is the greatest joy from being an IO psychologist? A lot of times, because our work is about selecting the right people, developing the people so that they can maximize their potential. So maybe one of the biggest joy is actually seeing the right people progressing to leadership positions within an organization, where they can actually make decisions, good decisions, on behalf of the organization, such that the organization can be more forward-looking, and they can actually help to put in policies or practices that helps to engage people, that is beneficial for the welfare of the people. And you can see that as a whole, the organization is actually progressing. So I think actually that's something that I find joy in. So that's one area. And I think on a more personal level, what I also find joy in is actually growing IO psychology in the home team. So when I first joined many years ago, I think we're very small. Okay, so the group as a whole is very small, and over time we have developed, and I think IO psychology has grown to be an area, right, that's also quite important, fairly important in the home team. So we do have our work cut out in terms of helping the organization in terms of the people selection, the people development, and also the organization development. So I feel that over time, maybe in a small way, I have contributed to identifying certain individuals, the psychologists, and grooming them and helping everyone to grow as a part of the bigger family.
All right, so we've come to the end of this session. True? Yes.
Yes.
And hope you've enjoyed learning a little bit more about IO psychology work in the home team.
Okay, so if you want to find out more about what we do as psychologists in the home team, stay tuned for Inside Out.
Bye.